Good evening, everyone, and welcome to this evening's joint lecture from the Southeast Chapter Society of Critical Care Medicine and Gaspin. Thank you all for joining us. We always like to start our Southeast Chapter meetings off with our mission and vision. The mission of our chapter is to secure the highest quality care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. Our vision is that all critically ill and injured persons in the Southeast region will receive care from a present integrated team of dedicated, trained intensivists and critical care specialists, as well as inspire new leaders and providers of critical care in the region. We're going to start tonight off with a few announcements from our chapter, and then I'm going to hand it over to the president for Gaspin. I'll go ahead and introduce myself. I am Ashley DePriest. I'm a registered dietitian and clinical nutrition manager at Wellstar Kennestone in Marietta, Georgia, and I'm the president for the Southeast chapter of SCCM. Our Southeast chapter comprises of many states. I know we have a lot of folks here who maybe are not members, so just a little bit about our chapter. And again, our goal is to encourage SCCM membership as well as to build the Southeast chapter while providing education and networking opportunities. We have several QR codes throughout this, our announcements that you can take snap pictures of. So please feel free to do that to find out more information. Information on tonight's lecture in nutrition and metabolic needs in COVID-19 will be tonight. And like I said, Vivian Zhao will be presenting and introducing our speaker for tonight. But I wanted to give everybody a reminder and a save the date for our upcoming meeting, which is on June 10th, featuring Dr. Rhonda D'Angostino. And her topic will be sustaining wellness for healthcare professionals, not just a pandemic problem. So members can look for more information about this in your email coming up in the next few weeks. If you're not a chapter member, there'll be more information on our social media sites, and we'll talk a little bit about how to join our chapter in a few minutes. So very important slide here for everyone, whether you're a member or not, is our CE instructions. So we are offering free CE for this lecture for anyone, whether you are a member or not tonight, and that includes physician, nursing, pharmacist, and dietitian. So you want to make sure that you take a picture of this link, but this will also be sent to you in an email after tonight's lecture is complete. And you do have 2 weeks to complete the CE survey in order to get credit for your CE. So you have until March 8th, again, 2 weeks to complete this. If you have questions or you're having trouble, please email us at communications@sccmse.org prior to March 8th so that we can help you out and get that figured out for you. But there should be a form emailed to you, again, after tonight's lecture is complete. A few of other educational events we have coming up. We have our student-led critical care Twitter chats online journal club. The next one will be on June 24th at 1 p.m. Central Time. So follow us on SCCMSE on Twitter for more information on that. And if you're interested in participating or leading a Twitter journal club, you can email our social media chair, Caitlin Cundiff. Her email is there at the top, or DM us on Twitter at SCCMSE. And if you're interested in leading a Twitter chat, we'd love to hear your ideas. You can support the Southeast chapter by shopping with Amazon. Just a reminder, whenever you're ordering things on Amazon, I know a lot of us are doing that these days. Smile.amazon.com. With every purchase you make, they will donate a portion of your purchase price to our local chapter. We have another speaking opportunity for those who are looking to beef up their CV or their resume for members, chapter members only. We have our bite-sized lecture series. So the idea is that this comprises of 4 disciplines that come together to do bite-sized lectures, 15-minute lectures on a similar topic. So if you have an idea for this, you can email us at communications@sccmse.org. I know we have one coming up here in the spring with some folks from the Vanderbilt PICS Clinic, and they'll be giving us kind of an idea of a day in the life of an ICU, post-ICU PICS clinic. So lots of different disciplines will be sharing what they do for patients after they've exited and been discharged from the ICU and what they do to help them recover. So if you have ideas on another bite-sized lecture series topic, please email us. We also have National Critical Care Awareness and Recognition Month coming up, and as part of that each year, we award the Barbara A. McLean Contributions to Critical Care Nursing Award. So we're looking for nominations. I know this past year we've probably got so many examples of excellent nursing care, bedside nursing care. So if you have someone that you would like to recognize and nominate for this, you can email us at communications@sccmse.org. The Southeast Critical Care Summit has been rescheduled for September 8th, 2021. And again, you can check out the QR code there, or visit criticalcaresummit.com for more information on that. And again, like I mentioned, I know a lot of us here tonight maybe aren't Southeast Chapter members or GASPN members. So here's just a little more information on membership benefits. You do not have to be a national SCCM member in order to be a Southeast Chapter member. And more information on how to sign up can be found on our website at sccmse.org/membership. And here is our chapter leadership. If you have questions, please feel free to reach out to any of us. And as always, if you have topic ideas or would like to hear more about a specific topic, you can email our programming chair, Doug Smith. His email there is at the bottom of the slide for any kind of suggestions, speakers, topics, whatever ideas you have. And last but not least, get important chapter updates by visiting us on social media. You can visit our Twitter page, Facebook, we're active on both, as well as our website at sccmse.org. So now I'm going to be introducing our GASPN president, Vivian Zhao, and she will be introducing our speaker and giving a little update for GASPN.
Thank you, Ashley. Okay, so my name is Vivian Zhao. I am a clinical nutrition support pharmacist specialist at Emory University Hospital. I work with the nutrition support team for the last 15 years, and I'm currently serving as the GASPN president. Currently, we have a total of 12 voting board member and 1 observing board member. And here's a picture of some of our board member that have been working behind the scene to make everything happen. And I do want to make an announcement of a new exclusive GASPN member benefit. It is a new collaboration with the Children's Healthcare of Atlanta, which will offer access to nutrition support professional development WebEx events. It's usually 1 to 2 presentations per month on a Tuesday from 1 to 2 p.m. And this year, so far, we have 15 events scheduled. I know the time might be difficult for some of you, but all the WebEx event will be recorded and a link will be sent to all the participants a week after the presentations. This event actually offers 1-hour CEs for dietitians. Unfortunately, there's no CE for pharmacists and RN or MDs right now. It generally provides topics that covers pediatrics and adult nutrition. Here I list a few of the topics that are coming up. So nutrition and cystic fibrosis, vitamin supplementation in infant, children's, adolescents, medical nutrition therapy for diabetes management, and the impact of CRRT and micronutrient level in critical care patients. So there are many more. And if you are already a GASPN member, you probably already received an email last night to say just reply back to the email and I can enroll you. And if you're not GASPN member, you can join us for just $10 a year and you get great, education opportunities. And if you join, you can feel free to email us at gaspnga@gmail.com and then express your interest and also just send us a copy of your enrollment receipt. Then I'll enroll you in the WebEx. And we are currently busy planning our 2021 annual meeting. It is going to be virtual, and it'll be one of the Friday on either mid or late August. We haven't locked down a day yet. However, it will provide up to 4-hour CEs for physicians, nurses, dietitians, and pharmacists. And we're trying to focus on what topics are we going to be focusing, but definitely we will provide on pediatric and also adult nutrition. Something that is new for this year is that during last year's virtual conference, we actually have good feedback about our poster session through our YouTube channel. So this year we decided that we create a new award for all the GASPN member or someone who's submitting posters And then there will be an award for outstanding guest and poster. The winner will get a free registration for the next Aspen Nutrition and Science Conference. The due date for poster will be for July 31st, and then you can email your poster and abstract to gaspenga@gmail.com, and all informations are also available to our upcoming newsletter. And of course, we always love to have more people to get involved, and we have many committees, so feel free to email us, and if you're interested in joining to be part of the board or any of the committee. So lastly, there's one virtual keeping item. There is a question panel that you can see at the bottom. So please feel free to submit your question in the area at any time. Type in your questions and click send to submit, and we will have a quick Q&A session at the end of the presentation. So now it is a great pleasure for me to introduce our speaker, Dr. Paul Wischmeyer, who is a critical care, perioperative, and nutrition physician who served as a professor with tenure of anesthesiology and surgery at Duke University of Medicine in Durham, North Carolina. He also served as Associate Vice Chair for Clinical Research in the Department of Anesthesiology, Director of the Nutrition Support Team at Duke Hospital. Dr. Wischmeyer's clinical and research focus is in nutrition, critical care, and perioperative care to help patients prepare and recovering from acute illness and surgery. His research interests including surgical and ICU nutrition and rehabilitation therapy, perioperative optimizations, post-illness lean body mass and functional recovery, roles of probiotics and microbiome in illness, specifically COVID-19 prevention and treatment. Dr. Wischmeyer received numerous awards from national and international society, including the Jeffrey Silverstein Award and the Memorial Lecture for Humanism in Medicine from the American Delirium Society, the Honorary Samuel Rowan Lecture from the Royal College of Anesthesiology, the John M. Kinney Award for the most significant contribution to the field of general nutrition, the Stanley Dutcher Research Scholar Award of the American Society for Parenteral and Enteral Nutrition, where he also was an honorary fellow of Aspen. In 2020, he received the Aspen George Blackburn Clinical Nutrition Mentorship Award, as well as the Excellence in Nutrition Support Education Award. He has received the Lifetime Achievement Award of the International Parenteral Nutrition Education and the Methodology Advancement for significant contribution to the field of nutrition. Dr. Wischmeyer had over 180 publications in nutrition, critical care, perioperative care, including publications in the New England Journal of Medicine, with an H index of 59 and 39 papers with greater than 100 citations. He has been an invited speaker at numerous national and international medical meetings, delivering over 800 invited presentations over his career. He is also passionate about training and preparing new young physicians and scientists for careers in academic medicine, perioperative ICU care, and clinical nutrition. Finally, he is an advocate for and lecturer for improving the patient's experience and teaching providers to keep care as a focus of healthcare. Let's give a big welcome to Dr. Wischmeyer.
It's an honor to be here. I think I was muted there for a minute. And I look forward to talking to you tonight about nutrition and metabolic needs in COVID-19. And just briefly before we start, I'll show you what I believe to be my alignments of interest. I don't see them as conflicts since all of these foundations, the NIH and industry supporters, I think all of us are passionate about improving the outcomes of the patients we care for. So I don't think we're in conflict. I think we're actually in alignment. And then before we start, I'll leave this here. We have a few quick poll questions that I want to get a sense from the audience who I'm talking to and sort of a few things about you. So if we could launch those, let's do that now. Okay, great. Looks like largely dietitians, a few other groups involved. More folks than I thought it looks like have metabolic carts, but not too many. Great. Interesting. Great. Okay. All right, I think that is it. Great, thanks everybody. So let's get started here. So as we start to think about COVID-19 and the course of it, I think this is important because this is a disease that, for all of you who I'm sure have cared for this for far too long and far too many patients now, that changes over time. Clearly, we see changes and evolution of this disease from the initial viral response phase to this very extreme inflammatory response and activation of a range of inflammatory pathways. And we're beginning to believe that some form of inflammation, and there's conflicting reports about how severe the inflammation actually is versus other critical illness, but some form of inflammation and activation of other pathways, bradykinin perhaps, lead to the organ injury that we see when the patients come to the ICU and we care for them. But one thing we do have a good feel for is that the post-COVID syndrome and the post-COVID recovery of these patients is quite severe, quite severely debilitating to the patients who get it. And patients who aren't even in the ICU, and this is one of the early studies in JAMA that showed that patients have this long COVID syndrome of significant decreased quality of life, significant weakness, and significant fatigue that lasts for months. And this is not in the ICU patients. And so we can only imagine what the post-ICU weakness and PICS is going to be like as we begin to learn more about that in our COVID patients. And so we've begun to do research focused on this, and I'm going to talk about some of it tonight. And we have a number of hypotheses, and one is that there's a persistent hypermetabolic and hypercatabolic phenotype in COVID-19 that leads to what we're seeing as this long COVID or long hauler syndrome. And we believe it relates to inflammation, but activation of other pathways like bradykinin as well. And this leads to this hypermetabolic, persistent hypermetabolic state, other metabolic pathway dysfunction, and the mitochondrial dysfunction. And then this is what leads to the muscle wasting, the cardiac muscle injury as well, because the heart's a muscle, but also the body composition and muscle quality changes that we see that ultimately contribute to not just clinical morbidity, but also the muscle weakness and impaired quality of life that we're seeing. And we think that clearly what all of you do delivering nutrition and rehabilitation modifies this, and we believe we can begin to change it, as well as the drugs that are given. Again, a good example of that is propofol. Propofol we know is a mitochondrial toxin that impairs the ability to generate ATP and leads to muscle cell death when it's used for over 48 hours or over periods of time. And so again, we're using a lot of propofol, we all are, and it has toxicity to the mitochondria. It was never meant to be given in a prolonged infusion. And so we know it contributes to ICU-acquired weakness and prolongs that. And so that's something we have to be considering as well. Because again, I think the take-home message for all of us in nutrition and all of ICU, of course, is we need to take responsibility not just for outcomes in the ICU, but what happens afterwards as well. And so every day on rounds, we need to be thinking about not only what are we going to do to get the patient through today, but what are the things we can do today to ensure this patient goes back to a life that's worth living, a life where we're creating survivors from our ICU patients who leave our ICU and go home, and not victims. Patients that unfortunately, and we're seeing a lot of readmissions throughout the country of these COVID patients, not victims that never leave rehab, perhaps never go back to a quality of life that's worth living. Because ultimately our dream, right, is to have people leave the ICU after COVID or any of our ICU illnesses and be able to walk down the street with the people they love and be able to hold their grandkids and their children again and regain that quality of life they came to us to give back. And in COVID, this is tough. These are really difficult patients to care for. I don't need to belabor this. They're the most challenging to feed, or they're the most challenging to care for that many of us have seen in a long time. It really harkens back to the old forms of ARDS from when I was a resident and even before. So the good news, of course, overall in the ICU is that ICU mortality is decreasing over the last 10 years. And that has been true to some degree, especially in the ICU and COVID patients as well. We know that the ICU mortality was significant. It was terrifying in Europe and in China when this first started, in Italy and the like. And now it's significantly decreased across the United States. And for all of you who haven't seen it, just yesterday, an outstanding publication came out in Critical Care Medicine that all of you should look at if you haven't seen it yet, on outcomes of COVID-19 in patients that are in the ICU. And so if you don't get any organ support therapy, your mortality is very low, less than 10%, your length of stay is short. As soon as we intubate you and put you on a ventilator, your mortality goes up 5-fold. And so this is pretty devastating. And your length of stay triples and your discharge home rate plummets. And then, of course, when you start adding vasopressors and CRRT, those things get worse, as you might imagine. Look at that devastating discharge to home rate in the CRRT patients. So this is an outstanding virus registry paper that our society has really, really done a great job publishing. And that really begs the question in critical care, especially in COVID-19, are we winning some battles by saving lives, but perhaps losing the war sometimes because we're focused so much on the day-to-day patient care issues, we're losing track of ultimately the war to get the patient's lives back. Is it not sometimes a Pyrrhic victory where we so deplete the patient of muscle mass and of metabolic reserve and of all the other key features that allow for recovery to occur, that in saving the patient, we actually are losing the war? Because although sepsis deaths, and this is non-COVID data, but this is overall sepsis deaths, have fallen by half in the last years, we've not increased the number of patients going home, we've tripled the number of patients going to rehab. And we don't know if these patients ever went home. And so I think this is a really key feature. Clearly, we can save people in the ICU, but at what cost? Because it, again, improved hospital survival, but how many of these patients even live a year? And the data implies that as much as 50% of the mortality that occurs within a year of an ICU stay occurs after they leave us. And so again, we believe we're saving all these folks to go back to lives that mean something, but many of them aren't even living past rehab or even a few months. And so again, quality of life not only needs to become the focus of our future trials, as this paper implies, but also really needs to become the focus, I think, of a key part of what we do every day on rounds. Because the real question I think we should ask ourselves every day is, are we creating survivors or victims, and what can we do today to create survivors? Because again, just 2 lines on PICS, not that most of you need to know about PICS, but again, this is really compelling. These are ARDS patients, perhaps like COVID patients, who are in their 40s and 50s, this data. And again, half these patients won't go back to work in a year at these young ages. And a third of these patients will never go back to the jobs they did before because of the physical and cognitive deficits they're suffering while they're with us. And again, no one's immune to this. Kids get this, adults get this, older adults get this. And so no one is immune. This is, thanks to Wes Ely, this is a great slide. He always shows 60 to 80% of people on a vent for more than a week will have significant functional impairments, some that are lifelong. And in this epidemic, from what we're seeing, what COVID-19 is doing, even in non-ICU survivors, this is going to be worse. And again, the average time on the ventilators you saw in that data before is really long. And so all of our patients are going to have some form, if not some form of severe ICU-acquired weakness and PICS. And again, this is limiting us in our physical therapy even, right? It's very difficult to walk someone on a ventilator who doesn't have COVID, but now, of course, we isolate them and they're very limited in what they can do. And I would love to hear if any of you are mobilizing your intubated COVID patients. We have not been successful at that at Duke, although we would love to try. So why are we losing this quality of life war? Why is this happening and what can we do about it? So we know ICU and major surgery patients, and we've seen this in COVID as well, can lose up to 1 kilogram of lean body mass a day. And again, how long do you think you can survive that? This is clearly indicative of the hypermetabolism and catabolism that can persist for months to years. For instance, a burn child will remain catabolic for 2 years after they leave the burn unit. and they're well. And so the body we're not evolved as humans to survive critical illness or severe COVID-19. And so our body doesn't know when to shut it off. And it seems like this may be worse in COVID-19. I'm going to show you some data that unfortunately supports this hypermetabolism may be worse. So this is an epidemic, really. Of course, we know this is a pandemic, and we must strive to do better, but how? And of course, to do better, it's going to take nutrition, which is the fundamental building block, one of the fundamental building blocks of recovery, good physical therapy, both in and after the hospital. And then I'm going to make a mention of some of the elite athlete techniques that athletes use that I think our patients that we've worked so hard to survive their marathon of their lives, that they deserve as well. So again, how to give nutrition in these patients. And I think the first message I want to leave with you, and I think this is something that we're finally on the precipice in nutrition and critical care nutrition of being able to address, is one size does not fit all. We really need to personalize our feeding. We need to be giving the right dose in the right patient at the right time, and we need to be measuring. And I think finally we can begin to do that. So how do we put this data into practice for our COVID patients? And what are our initial guidelines saying? Again, the guidelines largely have adapted our other critical care guidelines for COVID, and what can we learn from worldwide experience? So to talk about this, I'm going to talk about a similar patient to one I took care of early on in the pandemic. And his name was Elijah, and he was a 49-year-old African-American male. He was a professor at one of the universities in town. Cough and fever for 7 days. Wife and brother both had COVID, and he got it as well, sadly. You know, he came in just on a few liters, and he'd actually had surgery recently, which again is one of the many comorbid conditions that may set people up to worse outcomes. We know comorbidities significantly contribute to mortality and risk. So again, within 6 hours of admission, he decompensates rapidly and requires intubation. In the ICU, he has the typical severe COVID ABG. His PDAF ratio is 52, which these are some of the kinds of patients that go on to ECMO, obviously, in all of our centers around the world and around the country. But you know, we try the things first. He's asynchronous with the ventilator. He's paralyzed very quickly, much quicker than we used to paralyze people. This disease, very severe hypoxia, and then he's prone. And so I've prone more people in the last few months than I had prone in my whole career combined, of course, and I'm sure you have too. And so this is a challenge. It seems inevitable as soon as we sedate them deeply and prone them, they need Levofed. I'm not sure that's from the COVID as much as it is from all the sedation combined with the COVID. And he has pretty severe vent settings, but he's got a good heart, and he's delivering oxygen while his lactate's low. So what do our recommendations say? Our recommendations clearly say that we should start early enteral nutrition, just like we would in any other ICU patient, within 24 to 36 hours of admission and within 12 hours of intubation, much like in the burn world, where we start very quickly. And the sooner you start, the more successful you'll be, I will tell you from experience. And using in G-tube, we're avoiding post-parallelic feeding largely because there's risks placing the tube. And I have to tell you, I think the stomach is a great monitor for the prone patient who's very sick on pressors. And remember, COVID infects the gut. And so these patients have more GI issues and are harder to feed, I think, than the average ICU patient who's already hard to feed. So again, this patient's on pressors. And what about enteral feeding on pressors? I get this question a lot in the Facebook COVID-19 groups. A lot of you are probably members of that. Well, it was timely. Just last fall, I was asked to write this paper for critical care medicine about what's the data say about enteral nutrition and the support of giving enteral nutrition on vasopressors. And what I found when I reviewed the data was feeding on vasopressors may not only be safe in many or most patients once they're resuscitated, but also save lives, which I don't think I realized the extent of the data that supported that. And I won't go over it all, but I think this is a critical study. If you have an attending physician in your institution, in your ICUs, that says, oh, I don't want to feed the patient on pressors, it's not safe, they'll get gut ischemia. This is 52,500 patients in Japan that were critically ill on norepinephrine or another vasopressor. And they split them into two groups. Those that got enteral nutrition within 2 days, early group, those that got enteral nutrition after 2 days. And they looked at outcomes. And what they found was the 28-day mortality rate was significantly lower in the early enteral nutrition group at both the low dose, less than 0.1 mics per kilo per minute, at the medium dose, 1.1 to even 0.3, which is higher than a lot of us would feed at. And there wasn't any difference in mortality in the high dose. And again, this is a very high dose. So this was fascinating, right? This gives us the impression that a very large group of patients in real clinical practice that perhaps vasopressors, big feeding on vasopressors actually saves lives. And I think this is compelling. And I think the results show that early enteral nutrition is associated with a reduction in mortality at even medium doses up to 0.3. And so I think there's some thoughts we need to share on how to do this safely. And I think we think this is true not just because of the nutritional part of nutrition, but the non-nutritional benefits of nutrition, including things like preserving gut microbiome. Feeding stimulates the vagus nerve. When there's food in your stomach, it stimulates the vagus nerve, which causes anti-inflammation to be spread throughout the body and reduces organ injury, we hope. And then it reduces the toxic lymph that our lungs see, and improves gut barrier function. So I think even trophic feeding, and there's some new data that's came out in the last few months that even shows trophic feeding may be more beneficial than full feeding in these patients on pressors. But I think there's some key things that you need to think about if you're going to do this. One is the patient has to be resuscitated, right? And I won't go through all this table, but you can find this in the paper, and I'm happy to send you this paper if you don't have it, if you want to email me. But they've got to be resuscitated, have a normal lactate, vasopressor dose falling, good mixed venous. And then I feel most confident in the 0.1 to 0.2 ranges, although the data might imply that at multiple ranges of this norepinephrine drug in particular, there may be benefit to the patient. And the choice of vasopressor to use actually seems to matter from different studies. So norepinephrine seems to be the safest and actually preserve gut blood flow and tolerate and improve gut blood flow the best. Dobutamine and phenylephrine are with that kind of. Epi seems to be second, and then vasopressin and dopamine are the worst. We used to use vasopressin to stop GI bleeds and constrict off the gut when I was a resident. That was before we used it as a sepsis drug. And then start with trophic feed, start slow, and watch for signs of intolerance. I don't want to give anyone the idea they should go back to checking gastric residuals, but when we're feeding on pressors, I think you should use that 500 cutoff just for that period they're on pressors to be sure that you're not missing something, and that's why I like to feed the stomach. And consider elemental feeds perhaps in these patients as well. And then watch for signs of intolerance. Clearly, I think that's essential because I think that's your best judge. And so I think a couple key points to take home: feed the stomach, not the small bowel, because you'll miss these signs potentially. And I do watch in my pressor patients for residual over 500 because it's a good monitor. So what about bolus intermittent feeding? Early on in the pandemic, and perhaps even more recently, I got a lot of messages from RDs that said, gosh, I've run out of feeding pumps and I need to know, can I feed through syringe boluses? And the data is now more and more, actually, it's definitely safe to do. There's a lot of papers here. If you guys want to take a picture of this slide, you can look these papers up. Some of them are about outstanding dietitians around the world, people like Danny Bear and others. And it may have some benefits, actually. And there's existing data that shows that this is safe. It doesn't seem to increase gastric intolerance, and it actually may be more beneficial for preventing muscle loss and stimulating muscle gain, right? Where we as humans don't feed ourselves continuously. There actually seems to be a signal when amino acid levels in the blood go from low to high to stimulate muscle synthesis. And so again, if it worked to stimulate muscle by tube feeding, every bodybuilder would have a tube down their nose every night, but that doesn't actually work. We've actually been tube feeding before I ever came to Duke by bolus in our trauma and our ENT patients at Duke for many years, and I've seen it work very, very well and be very safe. And there's new data. Danny Bear and Zudin Puccicherry just published this last year, and they looked at intermittent feeding, and I'll leave it to you to look at the paper on muscle wasting and also safety, but it showed it was safe and actually improved the delivery of feeding. This is one strategy for that. I won't belabor this. This is in the Merrick paper if you want to find it. We usually do like 180 cc's Q3. I think that's one good strategy. So now you have this patient who's on Levophed, he's on the vent, and again, he's resuscitated. And so our patient question that we often get the most as well is, can we feed in prone patients? I think all of us are seeing a whole new world now of the need to feed in prone patients because our patients are prone all the time. And our SCCM ASPEN guidelines actually, and there's studies to back this up, show that eating in prone patients is not associated with increased risk of aspiration or complications, and we recommend doing it. And we are regularly doing this at Duke, and Leslie, our great SICU dietitian, and our MICU dietitians, Kate and all, have been doing this. And so again, most prone patients do the best to deliver to the stomach, and I tip the bed up a little bit just to keep the aspiration low. But the good news is, of course, with their face down, if they do regurgitate some, it usually comes out the mouth. And remember, the airway theoretically is protected by the endotracheal cuff. So again, we should be feeding our prone patients. I think that's key. And then the question becomes how much to feed, right? This is a whole new disease, how much to feed. And our guidelines kind of have reverted back to our traditional guidelines before COVID. And they say advance slowly, 70 to 80% of requirements over the first few days, and get to a good protein goal. And so why do we say this? Why do we say only give sort of half or 2/3 of the non-protein calories a patient needs? Well, remember that a well-nourished patient, when a patient gets stressed, will break down muscle to generate amino acids and glucose. It's sort of our metabolic reserve. And so the body can generate 50 to 75% of its non-protein glucose requirements without us feeding. And so if we feed a 50 or 100, 75 or 100%, sorry, and the body's generating 50 to 75% for the first few days, we're overfeeding theoretically. It's hard to demonstrate exactly what the body's generating, but this is what we believe to be true. And so exogenous glucose calories probably aren't needed for the first few days, nearly to the degree they would be perhaps later. And this is borne out by this nice study by Pierre Singer that showed that in 1,100 patients, the lowest mortality early in critical illness was when you got to 70% of measured resting energy expenditure. And so this has helped to drive those guidelines. This is a nice paper. But this is a new disease. COVID-19 is a new pandemic disease, and we need actual data. And so that was one of the things that we really wanted to seek to do. And if we're going to get actual data, we need to be using indirect calorimetry. That's why I asked you that question at the beginning of the lecture. And our guidelines all say, clearly, if available, this should be the gold standard by which we're feeding our patients. We wouldn't give vasopressors without measuring blood pressure. I think all of us in this modern era should not be feeding without measuring our patients' needs. ICU care is all about objective data. And I think if we want to convince our attendings and the physicians to value feeding more, we will get objective data to show what our needs are, what the RQs demonstrating their substrate needs are. We need data, and indirect calorimetry is how you get that data. And so even in COVID-19, ESPEN guidelines suggest this can be done safely, and I'm going to show you it can be done safely, and it should be used. And so that guideline actually in the original, not the COVID guidelines, but the ICU guidelines showed that studies that use indirect calorimetry to look at hypocaloric nutrition versus full feed nutrition were much more likely to be positive for the full feeding of nutrition when an indirect calorimeter was used. The p-value was 0.07. And this is so we avoid overfeeding, which is risks, and underfeeding, that is risks, and actually feeds to target, which I think this data begins to show us is going to improve outcomes. And so, of course, the challenge was we didn't have a calorimeter in our hospitals that was reasonably easy to use, that an RD could drive the use of, and that could be practically used without a lot of work and calibration. Well, a group of physicians from around the world, and I was honored to be part of that group, Claude Pichard led it with others from Europe, developed a new indirect calorimeter with industry. ESPEN funded this. We worked with Cosmed, and we tried to overcome all of the issues that were faced by the old indirect calorimeters and make a RD-friendly, ICU-friendly indirect calorimeter that anyone can use. And we published the validation of this calorimeter in this paper here, the ICALIC project, and this was the result. This Q-Energy calorimeter is exceedingly accurate. It's validated by mass spec, the gold standard. It warms up rapidly. It calibrates itself. Anyone can use it. It's about this big. It's really, really a joy to use. And it's accurate. It's easy to use. It measures, we found accurate in 10 minutes in most patients, just as accurate as 30 minutes. So it's very fast. And so we had begun a study of this in ARDS patients at Duke right when COVID hit. And so we quickly pivoted. We had a number of these machines, actually the first in the US. We were lucky to get to do this study. We quickly pivoted to studying COVID-19 disease. This is Jeroen Mullinger, who has spent the last almost, I guess, 10 months, 9 months in and out of COVID rooms, spending hundreds and maybe thousands of hours now doing different kinds of measurements and metabolic measurements on COVID patients. He's really, really been a hero doing all this work. Actually, some of this data is published. You'll see this reference down below, but we're going to talk about the data. And so we really needed to understand what the longitudinal data throughout ICU stay and maybe even after, what happens to metabolism in these patients and how do we know how much to feed them? And that was the idea of the study. We did a bunch of measures. We did routine, regular measures. We used that junior generation metabolic cart, muscle-specific ultrasound, BIA, body composition, and then echocardiography. We wanted to look at the heart as well. And so the first question we had is, are COVID-19 patients as hypermetabolic as we think they may be early on, or do they look more like the 70% of needs hypocatabolic? We didn't know. We didn't have a guess yet. So this is some examples of what we found. This is a patient in the first few days of their COVID-19 disease. It's a 50-year-old patient from a nursing home, 60 kilos, spontaneously breathing on the vent, not paralyzed, so not severely ill as others, but only 70% of Harris-Benedict predicted, so hypometabolic. Again, we would not necessarily have predicted this person has COVID-19. They're intubated. We think of the hyperinflammatory. That's not what we found in the first few days in many of our patients. And again, this is the patient I was telling you about, the example of the patient, the case we're talking about. This is day 4 for that gentleman. And he only read out at 78% of Harris-Benedict predicted in those first few days. And he was very sick, prone and paralyzed, only needing 18 kcals per kilo, which our dietitian had guessed, Leslie had guessed right on. She was very accurate in her guesses in that first week. So what about as they move past day 5 to 7? All of us hypothesize their caloric needs go up, but is that actually true in COVID? This is the same patient now that you saw that was about 70, 80% of predicted. Now he's day 12, and he's 165% of predicted. Now, of course, it's hard to know that transition has occurred. And so he's still getting 20 to 25 kcals per kilo, but his actual needs were 35 kcals per kilo. And so we had to adjust his feeding up to meet that. And that's one of the, of course, benefits of the metabolic cart. This is day 15, it went up even more. Now he's at 3,000 calories, looks like a burn patient, 44 kcals per kilo. And so we had to adjust again. And so again, these patients have dramatic changes from day to day or week to week in their care. This is day 18, he dropped significantly. He looked a little better, he was starting to wean. He dropped back to 130% of predicted. So again, we want to overfeed him if we had just left him where we had him a few days before by the measurement. So regular measurements are needed. Look at the dramatic changes that are happening day to day. And so again, now we're at day 23. He got sick again. He got a secondary infection. And unfortunately, he also was being fed poorly, which you can see from his RQ being so low at 0.7. That's a protein breakdown kind of RQ. But he still was needing 35 kcals per kilo now as he continued to remain quite critically ill. And so this was the group as a whole that we published. Again, our average age was 58, about half were male, more than half were African American. Again, our minority and underserved populations are really being hit hard by this. The average BMI of our patients was above 30, almost 31. The majority were obese. And again, they had long ventilator stays, relatively good ICU and hospital mortality initially. And I'll show you some more data to show that you know, is getting more challenging, and I don't know why, but this is what we found in this first group. And so here's some of the data that we saw. Here's the change in absolute needs of calories per day over time up to day 21. You can see there's a progressive increase in caloric need in these patients, whether you're obese or non-obese. We had numbers in the 26 to 30 kcal per kilo range by the third week. So dramatic hypermetabolism, but not in the first week. So there were real dramatic changes that occurred in these patients. And again, they were very difficult to feed, and I won't belabor that point. I know you've all experienced that. John Whittle was an ICU physician that worked with us. Sadly, he's gone back to England to be with his family and work there, but he did a lot of this analysis. These are our VO2 and VCO2 measurements and our RQs over time in the ICU in COVID-19. This was the average caloric needs. You can see the big error bars, a lot of variability with this increase around day 15. This is measured resting expenditure on actual body weight, and this is everybody. So now let's go to the non-obese patient group, because I think it's really important that we split these up a bit. And then you can see the Harris-Benedict predicted there in red. And again, they got quite hypermetabolic after day 7 with large variability in that second and third week, but significant needs above, sometimes often above 30 kcals per kilo. This is comparing this is the obese patient data. We looked at both measured resting expenditure and then also adjusted body weight as well. Those are those two lines you see above. And then these are the aspirin projections, and all of the patients were far above the aspirin 14 kcal projections that you can see there in green. And this is comparing the obese and non-obese. Not so different, although I'll show you some more data. I'm going to take it up to about 40 patients here in a minute with some new data our RDs have put together. But this was our initial cohort, and you can see they were both above predicted Harris-Benedict, although a hypometabolic phase, and especially the obese patients early on. This is Krista Haynes. She's another one of our nutrition team leaders in our ICU. She's a phenomenal young researcher in our group. She's a surgeon. And this is the variability that we saw in their resting energy expenditures from day to day. We grouped them in 3-day groups. You can see the incredible variability, which is why we need to do measurements. We need the metabolic cart. No equation could ever predict this accurately, right? So we looked at how sick the patients were, and there was a fairly similar use of prone positioning and paralysis throughout their stay, and a fairly similar organ failure score. So that didn't seem to be what was causing the hypermetabolism and the perhaps hypometabolism we saw early in the hypermetabolism late. And then this is the number of patients enrolled over time, and then the prone rate and the paralyzation rate over time. And then again, fairly consistent organ failure scores. That didn't seem to be the driver. So our initial data shows in the first 3 to 7 days, they're fairly normal metabolic, with some being hypometabolic versus the equations. And then they become much more hypermetabolic, even beyond 200% of predicted in some patients. So very difficult to predict with equations, and we'll look at that. We did find in the first ICU week, somewhere between 20 and 22 kcals per kilo is probably a good match, especially for the BMI less than 30, and more like 19 kcals per kilo I'll show you in the obese patients. And then after that, again, I think it's worthwhile. I mean, for that first 5 days, it's worthwhile feeding 70% of that goal to prevent overfeeding. And so then after day 7, a lot of variability exists, and we learned some things. The older patients have lower kcal needs, so older patients probably you can down the amount of target a little bit. Obese patients seem to need a lot, especially after the first week. They have very high rates, and we'll talk about that because we have some new data that may say not quite that high, but we'll look. And then fever clearly plays a role in this, and it considerably increases the needs as patients chew through their energy. And so I think some other things we found, hypermetabolism doesn't seem to relate to organ failure or to paralysis. And that's not new. You know, you'd think if a paralyzed patient, they would have less hypermetabolic needs or less hypermetabolic state measured. But we're not the first to publish this. That doesn't seem to be true. This was a study that Arthur Van Zanten did where he looked at the effects of measuring by metabolic cart patients who were not paralyzed and then who were paralyzed. And the effect on resting energy expenditure is very small, about 6%. Probably not clinically meaningful, and I don't think you need to be adjusting for paralyzed patients. So, you know, we always try to guess at what our patients are doing, and this is the curves we've all drawn in papers, but this was the actual data that we measured in our patients. So again, hypometabolic early and then increased needs above what even we've guessed late. And so I think this is important. But then the question is, now we have more patients to talk about, how well do existing equations that we're all using, for those of you who don't have indirect calorimetry, how well do they perform? And I'm going to tell you, our dietitian research group found that not very well. So this is Hillary and our Laura and Nieder, who are both research dietitians on our team. They're also practicing clinical dietitians, and they did all this analysis, and they actually reanalyzed the data because I wanted to show you some of the late data. They just finished it yesterday, so they worked all weekend on it so that you guys can see it. We have 38 patients in this group, and we compared to existing equations. Again, now we have a little bit bigger group. The data's changed a little bit. Their length of ventilation is 20 days. So their ICU length of stay is 25 days. The mortality's gone up some to 32%. And then most of them are getting remdesivir and other drugs. So this is what the population looked like. And so you can see that. So this is what the indirect calorimetry looked like in week 1, 2, 3, and 4 now in this larger population. You can actually see that just on raw calories alone, it doesn't change much in the first 2 weeks. That's some of the weight differences in patient-to-patient groups. And then, but you can see the indirect kcals per kilo need measured goes up steadily all the way to week 3 and then persists out to weeks 4 to 7. We don't have a lot of measurements out there, but the data consistently seemed, and the standard deviation is even smaller out there, that they stayed hypermetabolic quite long. And I will tell you guys, you're the first ones to ever see this data. So I was excited we could get this done, and really it's all a tribute to Laura Hiller and Krista Haynes who helped them. So these are how the equations would have predicted them on the days they were measured. You could see the MSJ performs very poorly. Harris Benedict, not so great either. And none of these equations predict the hypermetabolic state that's occurring. I will hint one of them performs better than the others when I show you the rest of the data, but none of them can predict this hypermetabolic state. They just can't account for it in any way because they're not built to. They're not built to account for patient, interpersonal and patient variation. Obesity did seem to play a role. It's very interesting. This is week 1 data. You know, our data has shown an elevation in their first week needs as we've gone further out. And I think that's because we're intubating patients later. I can't prove that yet. We're looking at it. But, you know, we used to intubate people within hours of hitting the ICU because we were terrified of them. Now we desperately don't want to intubate them, and they'll go much longer before we're putting the tube in. And so they're getting through the first week sometimes without being intubated. And I think that's driving some of this data, but then they increase. The obese patients usually stay about the same, our data is showing right now, as we get more and more patients. And that may be, again, related to the fact we're intubating them later. These are how the equations perform. It's a busy slide, but the ones highlighted in orange are the words there's statistical differences between the measured resting energy expenditure from indirect calorimetry and the equation prediction, both in week 1 and then we grouped weeks 2 and 3 to improve power. And you can see the MSJ performs terribly. It's all orange. Harris Benedict has its limitations as well. The Aspen sort of straight 30 kcals per kilo or 14 kcals per kilo doesn't perform all that well either. You can see Penn State appears to perform the best, but again, it doesn't pick up the hypermetabolic state very well at all in these patients. And so again, we try to look at variations of more than 10% week by week in patients. You can see MSJ is terrible. Harris Benedict pretty consistently underpredicts by more than 10% in all the weeks. Penn State does okay, but does very poorly later in care, especially weeks 2, 3, and 4. And then it overpredicts in week 1. So none of the equations is great in any of these states, and they just very poorly see the hypermetabolic state. And so we concluded, and we're submitting this for publication actually this week, that these equations don't do well and they don't recognize the progressive hypermetabolism. The one that does work the best is the Penn State. So I would suggest, at least with the data we have now, that that's the one you should probably be trying to use. to predict energy expenditure, but realize it's not going to pick up the hypermetabolism that is occurring after week 2. And so you need to account for that. So this is how we're suggesting to use the metabolic cart. This is actually going to be published in the next few days to a week in Nutrition and Clinical Practice, a paper that Jeanette Hassey asked me to write. And this figure is from that paper, and it talks about suggestions on when to do metabolic cart and how to use the data. And so I'll show this slide again, and this will come out in this paper, but if you want to take a picture of this, or if you want to get this paper once it's out, I'm happy to send it to you. But I think this goes all the way out to post-hospital discharge and tries to take the best of the data we have. Okay, nutrition needs to be the complete package, clearly, and we can't build a house without bricks, and you can't build muscle and recover patients without protein. And even more so than energy, we've been talking a lot about energy, protein needs go up significantly at day 1. The most our energy needs go up is about 2-fold, and that's in COVID patients or major burn patients, someday between day 15 and day 20. But our protein losses go up very quickly at day 1. And so I think a key concept to understand is the concept of anabolic resistance. And that's the idea that it takes more grams of protein to build the same amount of muscle as we age versus when we were young. So you have to take in more protein to build the same amount of muscle with aging. Now, not all aged people have low muscle mass. This guy does pretty well at age 70, although it takes more than just good nutrition and protein to look like that. But I think there's a lot we can learn from athletes, including the idea of bolusing protein, perhaps bolus feeds, taking in branch chains or leucine or H&B at night, especially before you go to bed or before the patients go to bed. And then, of course, rehab and strength training are essential. Because the anabolic resistance of critical care in COVID-19 perhaps is even worse, is quite severe, and it's probably going to take some of these other anabolic interventions like H&B, oxandrolone, or anticatabolics like propranolol to really make a dent in this and help our patients recover faster. But what we do know, of course, is that at least in non-COVID patients from about 3,000 patient study by Darren Hyland's group across the world, that every 30 grams a day you get into your patients and convince your ICU team to deliver, you're going to reduce mortality, our data has consistently shown. So this is a good goal. And again, this is that same study from Pierre Singer that shows that mortality continues to drop as protein intake increases over time. In fact, it continues to drop beyond 1.3 there. As you can see, there's weren't enough data points. And so again, unlike calories that sort of have this U-shaped curve, protein delivery really seems to improve outcome in our patients. And so again, that's a key part of the curve as well, getting protein delivery in. I think that's what we're trying to adapt. So unfortunately, and I don't want to belabor this because the dietitians and most of you are dietitians know this, we know we underfeed, especially in the US. And I think this should motivate all of us in the US to be better. We're always the least successful feeders in the world. We average 50% of patients' needs for not a few days, but for 2 weeks after admission. This is Darren Hyland's Critical Care Nutrition Survey. Some of you may have done this. And our protein delivery is even worse, 0.6 grams per kilo for 2 weeks in the ICU. This is really iatrogenesis and probably contributes to a lot of issues for our patients and a lot of post-ICU complications. And I think hopefully we'll continue to be able to show that. And so can feeding better improve post-ICU outcomes? And that's one of the questions I think is the sort of holy grail of nutrition delivery in the ICU. And we have some data that shows that. This is actually data that was drawn from the redox trial we did of looking at glutamine and antioxidants, but we specifically looked at the long stayers, like our COVID patients, on the ventilator more than 8 days, and we found the calories and protein goal that they reached, the percentage of goal they reached in the first 8 days, this is only the first 8 days, changed survivor probability at 180 days, so at 6 months. And so the better protein and calorie delivery you got in the first week, the better survival you had, but it also changed quality of life, and actually quite significantly and quite dramatically. These are 3 and 6 month quality of life scores in these patients, and there were significant improvements. These are very clinically meaningful to patients, these kinds of changes at 3 and 6 months. So again, how you feed in that first week seems to have an effect on quality of life months and perhaps years later. So this is a good motivation to get your patients fed in the first week and then continue to get that feeding done. So back to our patient, right? These are really challenging patients to feed, and he's stuck on trophic EN, and it's stopped multiple times. He's gastric residuals, he has a lot of intolerance and distension, and we're just not succeeding. He's getting less than 25% of his needs. So what do? So again, getting to goal EN is very difficult in these patients, and GI tract involvement is very common. And so again, this is a nice review of that if you want to read more about GI symptoms, but there's many papers like this. And so this infects the gut just as much as it infects any other organ. And so this is a challenge for us. And so even our guidelines are suggested, in contrast to other populations of ICU patients, we should be starting PN sooner in these patients. We think they're more hypermetabolic, their gut is affected, they're more challenging to feed. So we are suggesting earlier TPN use in these patients. And so in this patient, again, we're facing that same challenge. He's not being fed. And so I think it's really essential. But then the question you're going to get from your staff probably, and I know the RDs in the room probably know the answer, but doesn't it increase the risk of infection in our patients? And that's always the pushback. And of course, we know the answer to this now is no. And we know that now in 4 large trials and journals, I think everybody in your IC would have heard of, JAMA and in New England Journal and Lancet, TPN is just as safe to give to your patient as saline is to give to that central line in 2021. It does not increase infection risk. We have thousands of patients studied in numerous trials. This is a whole different world, and anyone who still thinks that, we need to set them straight. And that's that you guys as the RDs are the ones who are going to do that. So, and why is that? Well, there's a lot of reasons. We don't hyperalimentate anymore. There's no more 35 and 40 kcal per kilo of mostly dextrose. We actually treat hyperglycemia. When I was a resident, we didn't treat it till it was 300. Can you imagine why TPN caused infection when we weren't treating hyperglycemia? I used to have a cardiac surgeon tell me, let the glucose ride 350, it's a great diuretic. You can imagine what that did for people. Improved protein delivery helps, better central line care clearly helps, and then clearly improved lipids. And I saw only about half the listeners out there are using a new lipid, a fish or olive oil lipid. And I really encourage you to get your hospital to switch. If that's the one thing you take away from this lecture, that is a win for me and for your patients, because we finally have a range of new IV lipids in the US. Lipid choice matters to outcome. You know, there's meta-analysis of this, and this is an updated Pradelli meta-analysis looking at these combination lipids with olive oil and fish oil, 49 trials, numerous ICU and surgery patients, thousands of patients studied, significant reduction in infections from the use of these new lipids versus intralipid or omega-6 alone. This is a big change. I can tell you that the minute these came out, we at Duke made a wholesale switch in 2017. All our patients, kids and adults now, are getting an alternative fish and olive oil lipid. So I hope you guys do the same. And again, it reduces length of stay. This is a no-brainer to get through your pharmacy. The cost is minimal for these versus intralipid. And I strongly suggest you guys switch. And again, 56% reduction in sepsis. This is 1,000 patients studied. So this data is really strong and continues to grow, as we can see. So please use a new lipid to reduce infection and to improve your patients' outcomes. We've been waiting for 20 years in the US to get these. Now we have them, we need to use them. Now, one challenge when it comes to lipids, severe hypertriglyceridemia, and I'm sure you've seen this, even in low propofol doses have been seen in COVID patients. So you need to be monitoring that. I'm sure you all are, but I have to say it. We see it all the time, and I'm not a big fan of propofol. It clearly is a mitochondrial poison, contributes to ICU cardiac weakness, and so I try to find ways off of it every time I can while still avoiding benzos, which is a challenge. Quick other thing I think we can do to try to prevent infection in our patients. That's another thing I think that we as RDs or the nutrition team and you as RDs need to own is the patient's gut and what's in it. What's the data for probiotics and the role of the microbiome in preventing and treating respiratory infections? Well, there's actually some nice trials, and I think this is one of the best. This was an NIH-funded trial of probiotic prophylaxis to prevent venereal-associated pneumonia. So this is your COVID patient who's intubated and at risk for that devastating secondary pneumonia. And so this was a study that looked at giving a lactobacillus capsule to the mouth and one down the feeding tube. This was NIH funded. This was not industry funded. It led to a 50% reduction of venereal-associated pneumonia, reduced it by half in patients who got a probiotic. Really stellar data. It was published in the Blue Journal, our highest impact critical care journal. And this was even true in the intention to treat groups. This is strong data. Reduced C. diff infection as well, which again makes some sense. But this is a powerful data, and I've been starting when I'm on service, I've been starting all my COVID patients that are intubated on this, not just to help them with their COVID, which I'll mention in a minute, but also to prevent that secondary pneumonia. We've done meta-analysis of all the venereal-associated pneumonia and all the probiotic studies. Again, we see a good signal for reduction in infections, significant reduction of venereal-associated pneumonia, and the sicker you are, like COVID, the more they're benefited from probiotics because their microbiome's more deranged, we believe. So there's another trial you should know about because I think it's one of the best trials that's been done ever in nutrition and probiotic field. It was published in Nature, the journal of Nature, one of the premier impact factor journals in the whole world. And it was this huge trial done in India where they looked at a randomized double-blind placebo-controlled trial of a symbiotic lactobacillus plus fiber in Indian newborns, full-term healthy newborns, 4,500 of them. And what they found was that the newborns who got probiotics, it prevented sepsis and respiratory infections quite significantly, quite dramatically. So it had a major effect in preventing lower respiratory tract infections, sepsis, and death. And so significant reductions across the board, 40 to 50% from giving this simple probiotic that many of you probably have on formulary. And that included lower respiratory tract infections and viral infections. And so I think that's really exciting. And again, we've got other data, multi-center or multi-trial data, 3,700 patients, Cochrane data, reduces upper respiratory infections in adults, 47% adults and kids actually. So again, a 50% reduction in risk of the kinds of viral infections like COVID perhaps that we're seeing. And so again, this may be a way to prevent COVID-19 progression. And we're doing trials, research team I work with here at Duke, Tony Sung and others at Duke, and this is one of them. So if you have anyone in your household, anywhere in the United States that you are, that anyone you know who has somebody test positive in their household, we have a study where we'll send study probiotic or the control to them and swabs to collect some stool. And we would love to enroll them in the trial, and there's the website right there. So we're enrolling. We just were on the news here last week. We're trying to get more national news exposure. So again, back to Elijah. So unfortunately, as all is too common, he begins to have his urine output drop, and his creatinine bumps up from renal failure and ensuing oliguria and AKI. And so unfortunately, CRT has to be started. And so he's found, of course, he's positive, and he's day 21 now, and he acutely develops pancytopenia. His platelet count drops, his white count is less than 1,000, and this is about a week after CRT was started. So we ruled out all the drug-related etiologies, all the antibiotic causes of this, and is there a CRT-related metabolic nutritional loss that may be causing this patient's pancytopenia? And I'm guessing some of you in the audience know what micronutrient that might be. Well, the answer is copper. He had a very, very low copper level, less than 10, from losses from CRT. We gave it back, and his white count came right back up. But this was a life-threatening pancytopenia for this patient. And unfortunately, I've seen it too many times before in other settings on CRT. So again, a CRT machine is not a very smart kidney, and it will waste most all of our water-soluble trace elements and vitamins pretty rapidly within a few days, 5 to 7 days in many cases, including your amino acids. They go out the bottom of the bucket too. So it's just like putting a hole in the bucket. Your nutrients, your vitamins, your amino acids drain out the bottom. The machine doesn't know how to stop that. That's why we suggest higher protein delivery in patients on CRT, because we're losing about 30% of that protein delivery. And you should be checking or giving a lot of these things. And there's a lot of complications that can happen from deficiencies in these different micronutrients. Pancytopenia can be common with a number of the B vitamins and copper. You can have severe encephalopathy from B6 deficiency, and that is rapidly depleted on CRT. In fact, we scanned people for strokes, and all they were was they had a B6 level of 0. We give it and they wake right up. You can have permanent neuromuscular weakness from copper deficiency if it's not picked up. Again, that was discovered in the gastric bypass patients who stopped taking their vitamins and minerals. Carnitine can do that as well. And then the lactic acidosis from thiamine. Hopefully our deficiency states in the US will get more of this availability. So one of our soon-to-be ICU fellows did a great study of slicing and dicing data from EPIC with a new program to look at how much this is actually happening in our Duke ICU patients. And we found that 89% of patients on CRT developed one or more deficiencies in trace or water-soluble vitamins within just a few days, 5 to 7 days. And you can see the most common were copper. You can see vitamin B6 is very common, but others as well, carnitine as well. And so a majority of them developed these deficiencies. These are the most common. We also looked at high nutrition risk patients. And again, we also saw some of these deficiencies as well, B6 being one I didn't realize how common it was. We even saw some signals this may relate to mortality. Again, this is pretty raw data, and we are submitting it for publication now. But patients who are carnitine deficient versus not carnitine deficient on CRT had double the mortality in the groups that we studied. Again, there's many factors that can contribute to this, but it's interesting. So again, these show signals for increased mortality on CRT. And so these are things you need to be looking for. Any nutrient deficiency, any of those nutrients being deficient on CRT or just malnourished leads to an increased mortality risk of 2.4-fold in our data. Again, that can be multifactorial, but that was our initial data. So again, these are things you need to be looking for and checking, especially on CRT, copper, carnitine, and others. So our patient's getting better. Elijah's improving. Thankfully, he gets extubated, and he started on oral nutrition. He works his way back to be able to swallow. Will our ICU post-COVID patients eat enough on their own? And we know they won't. The average intake is about 700 calories a day. And so the only way we're going to get our patients what they need is oral nutrition supplements in the post-ICU setting. We know they reduce mortality. Many trials have shown this in the hospital setting. They reduce complications quite dramatically. And we know every dollar you spend on ONS, and again, this was about a 1.5 million patient study, saves $52 in hospital costs. This was a big health outcome study that was published recently. And so now we also have a large randomized trial that shows that high protein oral nutrition supplements with HMB given for 3 months after hospital discharge in 78 centers, 650 patients, reduced mortality by half. And so that's why we use H&B containing high protein neural nutrition supplements, because we have a large randomized trial to support this. And I think there's some benefits to that H&B component. But this should be essential for all our COVID patients to improve outcomes and reduce costs. I think we have to be doing this post-ICU. But then the question is the right nutrition enough to win the war? Because calorie delivery alone is not going to stop lean body mass. It will slow it, but by itself, it won't stop it. Again, we're not evolved for this. Mother Nature never intended our patients in the ICU or with COVID to survive once they're intubated. And our hypermetabolic state and catabolic state can persist for a long time, and these patients are very hypermetabolic. So can we learn from elite athletes who are really quite good at gaining muscle like this guy to help our patients recover? And of course, you have to do more than eat right to look like this. You can't just eat a lot of protein. And perhaps that includes taking the right anabolic agents. And so again, testosterone and those other anabolic agents shouldn't be given in the early phase, those first few days when they're really sick. But after that, the data gets much more promising. We know in burns, it reduces mortality, it reduces the number of surgeries they have, reduces length of stay. And I check my patients for just the total testosterone. It's much cheaper. It's an add-on test, comes back in a day. They're all deficient, and that's been published by others. It's not a new finding, but the deficiency is they're often less than 10. And we know that in burn injured patients, it improves survival. And this is common in all over the world, that oxandrolone and other testosterone agents are given to burn patients, even in South Africa and in India and in third world countries, but it's not being commonly done anywhere else. And so the question's always been, is it safe? Does it increase cardiovascular risk? And the answer is no. It actually reduces cardiovascular and stroke risk in patients who are deficient, and people who are deficient. 43,000 subjects in a JAMA paper, testosterone deficient subjects, were given testosterone versus not. The people who got testosterone had 33% less cardiovascular events, 30% less strokes, 34% less other cardiac related events. So it actually protects the heart. And so again, I think this is something worth checking and something worth repeating. You can do it a couple different ways. Oxandrolone is the best. If you have it, it's purely anabolic. Women and men can take it, no virilization. Testosterone cypionate should be out of there. 200 milligrams IMQ 2 weeks is not a bad way to do either. That's how I've been doing it largely at Duke. We don't have oxandrolone because we don't have a burn unit. So, but you got to give enough protein or it's not going to help. This is a paper we just published looking at this with people all around the country, if you want to see some summaries of this. But we really think that recovering patients, including COVID patients, maybe especially COVID patients, has to look at all the different things that contribute to weakness. And that's bed rest, inflammation, loss of anabolic hormones like testosterone, and then loss of appetite and malnutrition. And it's going to take a three-pronged approach, we think, to optimally recover our patients. And so again, I'm just going to touch on exercise here as we get close to finishing, because I think, again, exercise and recovery is essential for our patients. And we need to be looking to our elite athletes to learn how they overcome these incredible feats that they do and how they overcome the challenges they do, because this really is the marathon of our patient's life, surviving COVID-19 and being intubated. And again, the exercise can't look like this. This is not what athletes do, and this is not what our COVID patients, I think, can optimally expect is going to recover them. This is what elite athletes do, and this is what we are doing in our ICU and surgical patients, and we're about to start, I'm going to tell you, doing this in our COVID patients in their hospital rooms before they go home. So personalized exercise and nutrition rehabilitation training for ICU recovery is a reality. The future is now. We can do this, and we've been doing it at Duke, and other centers have been doing it. I'm going to tell you about a patient actually that we did a preoperative in this case, but I'll mention the COVID patients in a minute. This was a woman that came to us, and we did prehabilitation exercise using elite athlete techniques. She was on oxygen and largely confined to a wheelchair, and we were able to do this with her. So this is what our protocol looks like. It's a 3 to 6 week protocol. We do a CPET test to get their heart rate zones. We target their exercise with a card and the bike to their heart rate zones, the same that an Olympic athlete would do. And we do high intensity training with them, interval training, again, with intervals geared to them. And we give them high protein ONS with H&B twice a day, and especially after training, especially on their training days. We do it 3 times a week, and we've seen dramatic changes within just a few weeks. We can add 2 kilos of lean body mass to the lower extremity. This is measured by BIA. We can reduce their body fat mass in people who are obese. We can have a lot of positive effects. And we increase their measured exercise tolerance in just a few weeks, 3 to 4 weeks, by a whole MET, which is a significant change. That's a 15% lifetime mortality reduction if they sustain it. But this is in 3 to 4 weeks, and these are severely debilitated patients. We actually find the more severely debilitated you are, the more responsive you are to this interval training when it's targeted this way. And again, 1 MET is a big deal if they can sustain it. And all the patients we've done so far ask us how they can keep exercising when they go home. It seems to have a lifetime preventative effect on inspiring them to exercise. So we have transitioned this working with Wes Ely at Vanderbilt, and we're honored to receive the SCCM Discovery Award for the multi-center trials this year to do this for remotely monitored iPhone, iWatch monitored high intensity training program in COVID-19 ICU survivors. And we're looking to start this trial in the next few weeks, both at Duke and at Vanderbilt. And again, what we're doing is we're giving everybody an iPhone and an iWatch. We're doing a CPET test, a step test in their hospital room before they go home. And then we use heart rate targets from that CPET test to send them home. And then we include on the off 2 days, we do 3 HIIT training sessions a week, cardiovascular, and we do strength and balance on the off 2 days. And we use a Bluetooth CPET mask that's readily available to do this testing. This has already been done in bone marrow transplant with Tony Sung, and you can see we've had incredible compliance and adherence to this for even out to 12 weeks in patients who are severely debilitated BMT patients getting chemotherapy preparing for BMT. Our adherence is actually 117%. They exercise more than we ask them. It improves their VO2 peak by 25% in just 4 weeks. And they have very similar VO2 peaks as ARDS survivors have when you compare the two of them. So these are very similarly debilitated patients. So this is, we've just submitted this to the NIH as well. I'm gonna go back to that real quick. And we're hoping to do a large multi-center trial with Ohio State and Kentucky as well, looking at both outcomes, but also mitochondrial function and some other biomarkers in these patients. So this is, we hope the NIH will support us in taking this larger scale, and we're using the SCCM money to do the pilot. So there's some publications if you want to learn more about this kind of targeted exercise therapy. These are some of the papers we've published in the last little while. Happy to share these with you by email. So as I close, why is it that an anesthesiologist cares so much about nutrition and exercise in the ICU? It's kind of a strange thing to end up doing as an anesthesiologist. And this is why I hope you do as well. And I know that you do. I don't think anyone cares more than the dietitians that I work with. Well, I think the reality is we all should care, because Derek Angus has taught us that we're all going to average 1.7 ICU admissions over our lifetime. So for better or for worse, someday this may be you or unfortunately someone you love. And as some of you know, I've used up some of your lifetime supply of ICU stays myself, because early in my life, and for many different times in my life, this was me. This was me when I was 15 years old. I had inflammatory bowel disease and was in the hospital for a year when I was in high school. TPN saved my life. Dietitians saved my life, which is why I think I became so close and so endeared to nutritionists, especially into the dietitians that have been so fundamental in me still being here today to talk to you. I was in the hospital for a year on TPN for many, many months, in the ICU many times. I've had 23 abdominal surgeries and now live with about 160 centimeters of small bowel remaining, and an ostomy I've had since I was a child. And this is ICU preparation and recovery is something that's an everyday part of my life. This was me in 2014 with my son visiting my grandfather, probably in the best shape of my life. Not a month later, I ate some quinoa. Don't ever eat quinoa. It's a disaster if you've had surgery. And was away and ate some quinoa and got a bowel obstruction. This was actually my x-ray. Ended up in my own emergency department with a lactate of 10, bowel edema. We always go into the hospital way too late as medical folks. And was critically ill, headed to the operating room. Ended up in the operating room myself, ended up in my own surgical ICU, ultimately with an open abdomen for a period, for fear of bowel ischemia. I was hospitalized 23 days. This was just a few years ago. Unfortunately, I couldn't get the TPN calories I needed. I was writing my own TPN with my dietitians because I got soy lipid cholestasis. We didn't have the new lipids yet, and that's why it's so great that we do now. And I went from looking like this to looking like this in 17 days. I lost 20 kilos of weight. And so no one is immune for this. I couldn't walk down the hospital hallway without being short of breath within days of this occurring. It's unbelievable what this does, and COVID we think is even worse. Couldn't pick up my own child 5 months later, and as you can see at the time, he was pretty small. That's the weakness that it led to. So my ICU recovery and prehab are an everyday part of my life. And so what does that look like getting better, perhaps? What does it look like for me, and what does it perhaps look like for our COVID-19 patients? Well, over 2 years, 4,000 to 5,000 calories and 2 grams per kilo per day of protein that I eat every day. I like to show pictures of me with my ostomy. I was surfing right before this picture was taken, because so many of my patients who get ostomies, and I see a lot of them, think their life is over and they'll never be able to do anything again. And I say there's nothing that you can't do now that you could do before with an ostomy. You can do anything with an ostomy you could do before. And so I always hope it gives them hope. But I will tell you that that large calorie amount, Peter Collins in Australia has shared some data with me that shows in post-ICU survivors, to get them to gain weight and recover, it takes about 52 kcals per kilo, 52 kcals per kilo. So it really is quite dramatic what our patients need to recover meaningfully. These are the supplements I take every day. When I used to be able to travel, I had to take a separate suitcase for my supplements. I still take them every day. And so this is what I do to recover from the ICU and to prepare perhaps for that next surgery. How many of our patients will know what to do or how to do this? And we have opportunities to do better, but who's going to teach them? Well, the reality is you are. You're the dietitians are going to do this. And I think the key message is ICU recovery begins the day of ICU admission and continues long after hospital discharge. So in summary, how to address nutrition management COVID-19. Again, this is a disease that seems to lead to more severe muscle weakness, even in non-ICU patients. And so we really need to be getting on this early and really fighting hard late for our patients well into the recovery. And these are very difficult patients to feed, but if we're going to create survivors of our patients and not victims, we need to continue to strive to be better. And I think we're starting to get the data now to better target our nutrition. I think with indirect calorimetry and some of the other data that we're finally getting, we can target and personalize our feeds and measure it. Again, I think we're starting to come up with strategies and pathways that you can use. This will be out soon in publication. And I think there's a lot of opportunities to do other things, probiotics, perhaps oxandrolone and anabolic agents, doing metabolic heart measures, muscle ultrasound measures. I hope someday there's a muscle ultrasound probe in every one of your pockets, and it'll become to the dietitian what the stethoscope and blood pressure cuff is to the nurse, and you'll be able to measure these things every day on rounds. And so again, to kind of summarize what we said, I think we're finding 15 to 22 kcals per kilo in that first week is probably good. Ramp your protein up in day 1 to 3, keep it 0.8 to 1, and then you can ramp up after day 3. That's Arthur Van Zanten's data. It needs to go up even more in that second and third week. And then the recovery period, I think there's a lot of things, including exercise and other interventions, oxandrolone perhaps, and other things we need to do. But I think if we can learn to do this, we can take patients like this and maybe someday, at least in their rooms, be able to start walking them on their ventilators and have them go home looking like this, or at least like this. And this is my hope and dream for all of our patients, and you're the ones that can make this happen. So I think all we're left now is to just do it and make these things happen. You guys are the ones that'll do that. Feel free to follow me on Twitter and Instagram. I share a lot of new nutrition data, a lot of new COVID-19 data and ICU data on the nutrition care of patients on these sites, all my new papers and things, and other people's papers. And if you want any of these papers, feel free to email me at any time for these slides or for any of the papers I shared, and I'm always happy to answer questions. And so with that, I thank everybody for joining us tonight, and I look forward to your questions.
Wow, thank you so much, Dr. Wischmeyer. I always appreciate your anecdotal kind of just experience. It really adds to all of this. Thank you for sharing that. We have lots of questions tonight, so we're going to get through what we can, just kind of categorizing them. We're going to start with indirect calorimetry first. So one question we had was, how are you guys, I think you've spoken to this before, how are you guys handling the use of indirect calorimetry in the world of COVID and the safety of using that machine?
Sure. Yeah. You know, we put a lot of thought into how we were going to do this study and how we are going to do it safely, right? I mean, this is a really big question. And so we developed a system, which I'm happy to share with any of all of you, where, you know, we go in with all the PPE, and you saw your own all dressed up. And then what we do is we take saran wrap or like a sealed plastic bag, and we put it on either side of the circuit, the endotracheal tube and the ventilator circuit, with our metabolic cart connection inside of that sort of plastic wrap. And then we separate the circuit. Often we clamp the tube too momentarily, like we do when we prone sometimes, but we either turn the vent off for a second, or we clamp the circuit sometimes, but not always. In the really sick patients, we don't. But we do it inside that plastic wrap, and then we interplace the measurement device in there inside that plastic wrap so it can't aerosolize. And I think we found it to be very successful, very simple to do. I think I have some pictures somewhere. If you would like me to share them, I'm happy to do that. But it's really been an effective way to keep it from aerosolizing in the room and keep it safe for everyone. And I think everyone's felt pretty good about it. We went through all kinds of work with our nurses and our ICU physicians across our multiple ICUs that we're doing study in to do that. So this is something you can do. It's as simple as it sounds. You look at plastic wrap and you can make this happen. So I don't want you to be afraid of doing this in the COVID patient. This is definitely something you can do.
Excellent. Next question. I think many of our COVID patients and really severe COVID patients often end up with a pneumothorax and chest tubes. So are you still utilizing the indirect calorimetry for those patients, and how is that happening?
Yeah, so you're going to lose your indirect calorimetry if patients get pneumothoraces with those kinds of air leaks and things. If you're not collecting all the exhaled gas, your data is not going to be accurate. And so that is, of course, still, this metabolic card has overcome many limitations. You can go up to an FiO2 of 70%, which is very convenient in the world of COVID. We've tested people with PEEPs of 16 and very, very high PEEPs. So PEEP doesn't seem to be an adverse effector of this device, but leaks are. If you have a chest leak, if you have an air leak,
yeah,
that's not that we haven't figured out how to overcome. I will tell you, we've dabbled. We have enough devices that we are starting to dabble with putting on an ECMO. There are 2 publications looking at metabolic card and ECMO. To do that, you need 2 devices. You need one on the circuit. You need one on the patient. We're having trouble getting some of the results that some other investigators, both in Germany and then Elizabeth Dabali has got a paper out. And so we're trying to work the math out on that. But air leaks are not going to do it. CRRT seems to have a very minimal effect on it. We've done some testing of CRRT patients, both on CRT and after that's been stopped. We almost don't even see a difference. Sometimes we don't see any difference at all.
Interesting.
So I think the complication of CRRT, there's a small 5 or 10% VCO2 loss, perhaps in some patients. I'm not seeing it. We're not seeing it. We haven't published that, of course, but in our anecdotal comparisons, I think CRRT is not something that's beyond the scope that you could use this on and get pretty reasonable data.
Excellent. That's actually a really good segue into one question we did have about indirect calorimetry with CRRT. So we practice saying CRRT increases our needs. Is that reflected in the measurements from the indirect calorimetry machine?
Yeah, in the patients, and there aren't a lot I'm going to disclose, but the ones we've done some comparisons in, we haven't really seen a big difference or change. I think we need to do more, and Elizabeth Dabali also has some papers around this, but we haven't seen a big difference going on and off of CRRT. So from what I can tell so far, and I don't think I take this as gospel, my sense is no, I don't know that I would go adjusting your caloric delivery for CRRT until we have more data, at least in the COVID population. But I think that's something the jury's still out on and we need more research for. Now, clearly, as I mentioned, your protein and amino acid losses and your vitamin and micronutrient losses, especially water-soluble vitamins, obviously, are going to be really dramatic. And so that's something that you're really going to have to watch for. And I think a lot of us sort of didn't realize how significant that could be and the medical complications that could cause. So I would encourage that, of course.
Yeah. So in the case where it seems like, I think you said around half of our participants today don't have an indirect calorimetry machine. In those cases, can you go through maybe some of the markers or signals that we would look for either over or under feeding patients if we don't have an indirect calorimetry machine?
Yeah, I'm looking back at the poll right now, Ashley, and 22% said yes. So again, it's still a pretty small number, and I'm betting a chunk of those are the older metabolic carts that you have to go straight out to use, and we're concerned about their accuracy and things like that, just because they're hard to calibrate. I think if you're going to use an equation, use Penn State, from what I can tell from the data so far.
Yeah.
The challenge of Penn State is going to be, it is not going to account for that second, third, fourth, fifth week hypermetabolism. It seems to fall short on average 3 to 7 calories per kilo in those periods. I think if the patient is in that third week and is consistently febrile through the day, your needs are more. At least what we measure is dramatically more. They're just chewing through it. I think, as they get better and look better, they seem to be persistent in their hypermetabolic state, even as they get better, maybe needing more, which is what some of this post-ICU data is starting to tell us. And so I think, I would keep them up there. The time you need to worry about overfeeding is in that first week. I just have seen some patients even in the last few weeks when I've been on service. And this is where the question gets tricky, right? Now more and more patients come in and sit in our ICU on high flow or on OptiFlow, and they don't get intubated till they're 7 days in, right? So the ICU
right.
stay.
Yeah.
And and some of the elderly folks that we've measured recently, I have seen this hypometabolism even in patients who are 7 days into the ICU and then get intubated, and we measure them, say, a day or two later. I'm still seeing 80% of predicted in a lot of those patients. So I think we need to really drill down on that data and see, because I think, what I'm reporting is intubation day. I want you to be clear on, not ICU day, because we're only measuring intubated patients at the moment in the ICU setting. In the post ICU setting, we can do masks and hoods and things, but
It makes you wonder if maybe there's something about the actual intubation, whether it's a medication we're giving, whether it's the sedation or something along those lines that's decreasing it dramatically, and then it sort of gradually increases later.
Yeah, something clearly seems to change. Well, and again, I don't have a lot of pre-intubation data, but something seems to change when you drop that tube and start hanging with those drugs. And I guess I wonder, and this is only hypothesis based on the physiology of what propofol does, because they're almost all getting it right after they're intubated, right? It's a pretty good mitochondrial toxin, inhibits electron transport chain activity and inhibits flow of nutrients into the mitochondria. Is that leading to some metabolic dampening when the propofol starts? I don't know. I hope we can look back at our data someday and see that. But then, of course, they go way up in that second, especially third week. The third week is where they're the most dramatically up, and they seem to persist after that. And some of those patients still are on propofol, although, we try to find ways to get them off. But so I don't know exactly what happens, but I agree, actually, something happens when we intubate them, although I have noticed as we've been analyzing more and more patients who I think we're intubating later and later, that first week number is creeping up from our metabolic cart from, more like 20 in the first set of patients we did where we're intubating people early to more like 23, 24, maybe even a little higher sometimes in the non-obese patient. Now that we're intubating later. And so that may be some of that first week effect in the ICU where they're really sick, but they're not intubated yet. So I think, if you're in the 22 to 23 range and they're feeding 70% out of the first few days and then ramping that up, you're doing a good job. I think avoiding underfeeding in that first week, but still getting to some reasonable goal is a good goal. But getting to protein goals, I think after day 2 is important.
Perfect. Yes. Excellent. Great advice. I know Vivian Zhao, actually, also our Gaston president, does a lot of research and work on the CRRT and micronutrient supplementation. So we had a couple questions about that. One of them was about how frequently are you checking micronutrient levels and rechecking?
Yeah, we're working on our CMO has actually caught on to some of this data at Duke, and she's asked us to come up with a standardized pathway. Our CTICU APPs and team is for a couple of years now. That's where a lot of this data that you saw me present is coming from. Has got some standard orders they check at day 5 to 7 of CRT. I think by day 7, if they've been on CRT for a week, you ought to be probably checking some of these things. And I usually start with copper and B6 because those are the ones that have sort of the most adverse effects or at least easily visible adverse effects if they get really low. And if I see deficiencies in those, I start checking then selenium and zinc, although I will tell you, you can be selenium and zinc deficient and not copper deficient. So I don't want you to say it's universal, but the most common deficiencies are those. The other thing we've done is our RDs have worked hard. Our pharmacy sometimes switches oral vitamins sort of. It's hard to tell what vitamin we're using, but we found that, and I don't work for Centrum or have any relationship to them, but Centrum Silver seems to have the most of the things we're trying to replete. So we've been trying to start our CRT patients who can tolerate Enterol on Centrum Silver because it has copper in it, because that's hard to find. We had a Flintstones version that had it for a while, but then now we don't have it anymore.
Yeah.
So it has copper and has some other things. I also will tell you, if you notice carnitine deficiency or want to prophylax against it, 300 a day of IV carnitine will prevent this. Or treat it once he's been treated and keep them from getting deficient. If they are deficient, 600 a day will recover deficiency and not overshoot. And then after a week, I switch them to 300 and they seem to stay normal for the rest of their CRT. Some of these people are on CRT for months. And so we've had some luck. We do copper at about 4. We also do oral copper. We've had success with that, of course, too, if they'll tolerate it. Vitamin B6, 50 milligrams. For 5 or 6 days, we'll replete it. But the thing to know is if they stay on CRT, it's going to go down again if you don't keep giving it or repleting it. So we're looking for prophylactic strategies, to prevent this from happening in the first place, because checking these micronutrient levels aren't cheap and they take sometimes a few days to come back. But clearly the other ones we've seen are thiamine. Usually we're giving thiamine, and that's usually something that's in pretty reasonable amounts in our tube feeds and other things. Vitamin C can be 0 at times, as we all see. That's wasted pretty well by CRT. But the most common ones are the copper, the B6, and then carnitine, and then zinc and selenium. And day 7 is where I think we're going to create a standard check.
Yeah, I think it's important too, like you said, if they're tolerating Enterol, especially in these times of shortages, make sure you're using that route if you can, because so many IV vitamins are in shortage right now. So
it's really difficult, isn't it? Yeah.
So I have one more question, and then I think we're right at 7:30. So we do have many, many more questions in the chat box, but we want to be cognizant of Dr. Wischmeyer's time. So the last question is around oral supplements. So many of our supplements don't always have the HMB in it. So do you have a preference? Would you choose something that's higher in protein over something that has the HMB? Where do you kind of put the preferential treatment when it comes to HMB versus
Sure.
protein?
So I think because we have this large randomized controlled, 70 center, nearly 700 patients, post hospital, in hospital and post hospital, randomized controlled trial showing this benefit on outcome. We at Duke are regularly using, and I am advocating based on that randomized trial. And of course, I will disclose that I do consulting and research work with the company that makes that one, as well as many of the other companies. I try to discriminate. I think every company has good products, and I think everybody brings great stuff to the table. But I do choose that one because we have this large randomized trial, and I've seen the HMB data over the years, and there is some nice data. There's a nice paper that shows in bed-rested older adults that Nick Deutz, who's the editor-in-chief of Clinical Nutrition, your ESPN journal, he showed that actually patients who got HMB, older patients who got HMB didn't lose muscle mass when bed rested. Now these are relatively healthy volunteer elderly folks, but when they were bed rested, if they got HMB, they didn't lose muscle mass. Where if they weren't bed rested, they lost significant muscle mass over a few days. And so there's some pretty good studies in HIV and in cancer, but also some really robust studies done in the elderly folks and the older folks that show what a potent effect. It's an mTOR agonist, so it stimulates mTOR, reduces inflammation. It has some pretty interesting effects. So I choose the HMB formulas because of the data that this. I think if you don't have that, then the high protein oral nutrition supplements are the way to go. Clearly, the more protein they have, as long as it's whey protein, and I'm going to caveat that, I think the whey protein is clearly have been shown in muscle building to be better. I think it's what we as humans are geared to utilize amino acid wise, is the way to go, as long as the protein is of high quality.
Yeah, so HMB for sure.
Yeah,
excellent.
I think the data for the moment at least is supportive of that, and we'll continue to grow that data, I'm sure.
Yeah, excellent. I'm so sorry if we weren't able to get to your questions, you guys. I know there were a lot more great ones. Twitter's always a great place for that conversation too. So Dr. Wischmeyer, thank you so much. And for those of you who are here, we do have an encore presentation on Thursday. So share that with your friends who maybe weren't able to get registered today. We'll be sharing that information starting tomorrow morning on social media. So the registration will be accessible starting tomorrow. Again, thank you so much. We really appreciate it. This was excellent talk and so useful, so very useful.
Everybody.
Thank you.
Thanks, Ashley, and thanks everybody. And thanks for having me. And again, feel free to reach out, whether it's on Instagram, Twitter, or by email if there's questions you have or papers you want. I think we're all in this together, and this is something we can make a difference in.
Wonderful. Thank you. Bye, everyone.
Good night, everybody.